guess I'm not paid by a company. I do research I develop prognostic and predictive biomarkers. So this is really going to be sort of from an academician's standpoint, how we look at the Decipher test, which is a 22-gene genomic classifier test used in intact and in postoperative prostate cancer. And as all my academic talks, I always put disclosure. Pharma does pay me for a variety of things for trials I lead, but I don't take money from any of the genomics companies because I like them, but I also criticize them a lot in my publications. So I'm on the National Guidelines Committee, NCCN, which is essentially what makes the national guidelines for all of prostate cancer. And prostate cancer, there's about just under 200,000 new cases per year. About 3 million men walking around the US have prostate cancer, most common cancer in the United States for men. And the way we describe prostate cancer, we don't use staging like you do in most cancers where you get a stage 1, 2, 3, 4. We often use these prognostic groups. NCCN calls them very low to very high. These, importantly, were developed retrospectively, and I'll kind of discuss this, but we made, when I was back at Sloan Kettering, we basically, one of the big subgroups is called intermediate risk prostate cancer that's been now divided to favorable and unfavorable intermediate risk. And so what you'll basically see is that these risk groups, so what you're seeing here is low risk, intermediate, high risk. These sort of artificial divides were created in the 1990s, but that doesn't actually reflect a patient's risk of recurrence. And so kind of just trying to illustrate here, there are patients with low risk disease that actually have much more aggressive disease. Intermediate risk is likely the most heterogeneous, where there's some patients that need probably no treatment at all and some patients that likely will die from their disease. And so if you kind of look, what are the options in the national guidelines for treating intermediate risk patients, it goes from doing essentially nothing, which is watching them closely with PSA monitoring and biopsies. You could have surgery or radiation that are ballpark Medicare about $20,000, or you could go all the way to trimodal therapy, which can range over $80,000. We don't actually know because we bin these all together, and as I'll show you, our discriminatory capability of identifying who has indolent or aggressive disease is quite poor. And so as I said, Dr. Anthony D'Amico, who is actually at Harvard now, he put out a seminal paper in JAMA to define this low intermediate risk group, but that's over 20 years old now, and we still basically use that today. So how bad is it what we use today? So a coin flip, if I looked at a guy that I had in my clinic and I flipped a coin to say you're going to die of your disease or you're going to recur from your cancer or you're not, that would give me an AUC of about 0.5 or exactly. If I used our common prognostic variables, PSA, their T-stage, their Gleason score, they're a little bit better, but not much. And importantly, this is just biochemical recurrence, is the man's PSA rise. That's not a surrogate for survival. A man developing metastatic disease is a more important endpoint, which is shown to be a surrogate. When you actually look at NCCN, as I'll show you the data in a moment, its C-index, or AUC, is barely over a coin flip. And this is what I use every single day, unfortunately, to tell me if a man needs more intensive treatment or less intensive treatment. And so Decipher, shown here, it's a 22-gene test, but it's run on a whole transcriptome microarray. It already has approval in the post-prostatectomy setting to guide decision-making, as well as in low-risk and very low-risk prostate cancer. And so essentially, it's on a scale of 0 to 1, and it also gives you a score that they define as low, average, or high risk. And it'll tell you your chance of developing metastatic disease at 5 years. So this is a paper that I led, about 30 centers in the United States, published in JCO about a year ago. And essentially, what this paper shows you is this is our current NCCN classification from low risk, favorable and intermediate, unfavorable intermediate, and the higher risk groups. And this is not what you want to see these cumulative incidence curves looking like. You'd like these to all splay out, but what you see is that NCCN, basically, if you have favorable intermediate risk disease in yellow, you do basically the same as if you have low risk disease. And so this is not really discriminating which patients are actually going to harbor biologically aggressive disease. This is metastasis on the left. This is your chance of dying from prostate cancer on the right, and you'll actually see the low risk group is actually numerically higher than the favorable intermediate risk group. So this is a very poor performance. And you can see that here using CAPRA, which was developed at UCSF, they call it the best clinical model you could create. It's like NCCN on steroids. Using just these clinical and pathologic variables, none of them get over about 0.65 in that AUC. So they do better than a coin flip, but not much better. And this is using essentially every variable we have clinically or pathologically today. And so we developed essentially integrating Decipher into NCCN. And essentially, long story short, you can create new risk groups by combining with this genomic classifier these standard clinical variables. And this is what you get when you combine them. You see not only a lower risk, low risk group, where essentially almost no man dies of prostate cancer if you have this genetic score, but you identify a much larger high risk group as well. So almost half of these patients in this high risk group by current treatments are developing metastatic disease. And in validation, so this is all on biopsy patients, that is sort of what the indication for this test we're going for, is that not a single man out to 15 years developed metastatic disease if you harbor a low Decipher score. And again, at 10 years, about 50% of patients would develop metastatic disease with a high Decipher score. So when you think about those treatment options I discussed, you could very readily identify patients you probably want to do less or more on. And looking at its discriminatory capability, its AUC, you get around the 0.8s when you start adding Decipher to NCCN versus about 0.65 with NCCN. And so what's very relevant, so for this discussion, talking about favorable and unfavorable intermediate risk group, this is talking about reclassification. So what you see here, favorable intermediate risk, 44% will be classified as low risk. That means that these patients I would no longer do treatment on. I would watch them clinically. And about 40% would now have high risk, and we would add more intensive treatment aimed for cure. A cost of recurrence is very high. Additionally, 35% of the unfavorable intermediate risk groups, where we typically add multimodal therapy, we could de-intensify and omit that expensive therapy. New other data that we recently just published in Michigan, it's through Blue Cross Blue Shield. It's called the Music Registry. It's basically every urology practice in the state of Michigan. We looked at patients who essentially had no genomic test like Decipher done, and only about 4% of patients who had favorable intermediate risk disease would undergo active surveillance, meaning they'd just be monitored. But if you actually got the genomic classifier test and it had a low score, urologists were willing to put almost 30% of the patients on active surveillance. So the number needed to test to put someone on active surveillance or to change management was 3. So you order 3 of these tests, you're going to be increasing the rate of patients going active surveillance. And this is, again, without any guidance. Obviously, if you educated urologists and radiation oncologists, that number obviously would increase. This is just from them seeing the report. Another very important study that's relevant was done out of Princess Margaret Hospital in Canada. It was both favorable and unfavorable intermediate risk, a prospective cohort, the median follow-up almost 8 years. What's interesting is these patients all received just external beam radiation therapy, which most people in the United States would get external beam radiation with brachytherapy and or with hormone therapy. Almost none of them would be treated with radiation therapy alone. So, just to kind of summarize, these patients were getting less intensive therapy than most people would be considered the standard of care today. And what you'll appreciate here with long-term follow-up, those with a low Decipher score had 0 metastatic events, meaning with this less intensive therapy, you can achieve excellent cure rates. This was almost 60% of the cohort, where normally in clinic, if I did not have this test, they would all be getting bi, if not tri-modality therapy. As you see here, the AUC, NCCN, favorable, unfavorable, is an AUC of 0.54, barely better than a coin flip. Adding Decipher, 0.89. This is about as good as you're going to get with a single biopsy genomic test. This is another cohort. This is from the Harvard Hospital at Dana-Farber, and you'll actually see that this is in intermediate and high-risk patients. And even in these aggressive tumors, you can see that Decipher accurately stratifies low-risk to high-risk patients. And if you have a very low Decipher score, again, even though these had high-risk disease, not a single one of them developed metastatic disease. They were all cured. And so the implications of Decipher for intermediate risk disease, it identifies a large group of men that are candidates for less aggressive treatment. A large pool can now be observed or on active surveillance, And probably an equally large pool can get single modality therapy, radiation therapy or surgery, and they don't need the added costs of combination therapies and hormonal therapies. Not only is that an upfront cost, those therapies increase side effects down the road quite a bit. It also does identify a higher risk subset of patients that we do already have effective treatments for that could then undergo trials to intensify treatment. So this is sort of the new way that I sort of look at things based upon the research we've done is if you look at what I call the clinical genomics, so this is adding Decipher in, low risk, intermediate, high risk, you identify a very large pool of low risk disease. And this is why prostate cancer is viewed as indolent, but we haven't had a test to really reclassify these patients accurately. It also then creates this high risk group, and these are the patients, sadly, that's why prostate cancer is the second leading cause of death and more accurately identifies them. But if you go look at NCCN, what we use today, it's just a hodgepodge and a mess, and you can't really figure out which patient falls into which bin without genomics. Thank you so much.